Good morning, everybody. My name is Stacy Mazurko from University Hospital. Welcome. I'm going to introduce to you Mike Morrison. Dr. Adesani will be joining us shortly. He actually got called into an emergency. So we're going to start here with a video. So Mike is actually one of our surgical assistants who actually assists our cardiac surgeons in the operating room. And you'll see towards the end of the video today that Mike will be showing you a heart dissection, which you'll be seeing soon. But Mike assists our cardiac surgeons into the operating room. And you'll see a little bit more about that later. But right now, we're going to go ahead and give you a video where you're going to see when a patient has a heart attack, kind of a behind-the-scenes look of a patient coming from the emergency room and see what it's like for a patient to come through our cath lab and what happens.
911 emergency. My husband is falling. He's holding his chest. I don't know what to do.
Your heart always jumps a little bit of a beat when you see that there's a heart attack coming in. If you're on call, you drop what you're doing and off you go.
I think he's still breathing, but
We explain to them, your artery's blocked, you're having a heart attack, this is going to threaten your life. If we open the artery, you have a great likelihood of surviving this. From the time they hit the door to the time the artery is open, that's the goal. Time is muscle, saves lives. We are very good at that. We get it done very fast.
Get access, get support, and then we'll try to open the coronaries. Let me get going here.
Interventional cardiologists live for emergencies. That's what we like to do. We like to open a blocked artery that's associated with mortality reduction and survival.
What's our last blood pressure?
From the time you transfer the patient on the table and get this artery going, you have minutes.
You got a pulse there?
The typical finding on a heart attack is a blood clot obstructing a heart artery. The heart is like a motor. It's got a pump, a fuel line, and an electrical system. The fuel line brings oxygen and food to the heart muscle. If that's interrupted, the heart muscle dies.
Let's just get access on the other side. Once you get access on the other side, we'll get a balloon in.
You have a limited amount of time before that damage becomes irreversible. What we want to do is reestablish blood flow. So time is muscle. The sooner you get it open, you deliver oxygen and food to the muscle, it recovers.
Got it. 8 French balloon pump sheath going in. That's the left groin, left femoral. Good. 8 French sheath in. And good.
As we say, balloon up, and as soon as the balloon up goes, the recording technician marks that time, and then we have the emergency room time from when they hit the front door, and that marks your door to balloon time. So balloon up is a big statement in the lab.
Okay, we have an LED occlusion. Let's wire the lesion. We have BMW going down. We'll cross the lesion into the apex. Let's bring the balloon down. Balloon up. 12 atmospheres. Down at 10 seconds. Pull back, let's take a shot. Timmy 3 flow. Stop the clock.
Whenever we diagnose a patient with severe aortic stenosis, it's time to intervene. Basically, the two.
So now we're going to show you something. I hope everyone enjoyed that video. That was a real life case with doctors and nurses of a patient that had a heart attack. Now, Dr. Adesani, who you guys will all meet shortly, will be going over with you how we do a valve replacement in an awake and talking patient. Yes, they are awake and they're talking. So both Dr. Adesani, who is an interventional cardiologist, and Dr. Alan Markowitz, who's one of our cardiac surgeons, will review with you how we do this. And towards the end of the video, you're actually going to see the actual procedure room where they do the actual procedure.
Two options that we have to treat severe aortic stenosis, either surgical aortic valve replacement, so open heart surgery versus TAVR, or transcatheter aortic valve replacement. And if the patient is prohibitive surgical risk, well, then the patient is a candidate for TAVR. If the patient is high risk or moderate risk, the patient has an option. And then low risk, the patient has the option to be randomized in this controlled trial that we're comparing TAVR versus SAVR.
We were the first ones approved in the state where we are actually taking low-risk aortic stenosis patients, and we are running a randomized trial to truly examine whether catheter-based valve is better or equal to or not as good as surgical implantation.
From a patient perspective, it gives them all of the options to treat their aortic stenosis. If you go to another center and you're deemed a low-risk patient, you may only be offered an opportunity to have a surgical aortic valve replacement, but we can give you the option of enrolling in a clinical trial that'll give you the chance to be randomized to transcatheter aortic valve replacement. You're also providing information to the community for aortic stenosis in the medical community for how we treat patients in the future. How will aortic stenosis be treated 5 years from now? What will be the recommendations?
Some patients need to be put to sleep for the catheter-based valve technology, but the majority of them do not and can be handled with just intravenous sedation, and the anesthesiologist guides us through that process.
So last year, 95% of our patients we did under local anesthesia and very mild sedation using the femoral artery. We go from the groin to the heart under local anesthesia. Again, this is very important. Patient is talking and awake. The procedure lasts 1.5 to 2 hours.
With catheter-based technology, we become a national demonstration center to be able to do the catheter-based valve with a patient awake and under very mild sedation. This has tremendously diminished the incidence of certain complications that surround this procedure, and it has significantly shortened the length of time the patient has to be in the hospital afterward. It is also takes much less of a toll on the patient. And this is a patient in whom we are getting up and letting walk that afternoon and home within 2 to 3 days of the procedure. If we can do that, we really have accomplished something that is an extraordinary leap forward.
If you look at the TVT registry, which is the nationwide registry of transcatheter valve implantations, you'll see that the median length of stay is still 6 days. So it's much longer length of stay compared with hours that we perform the procedure under local anesthesia.
We are treating patients every single day of the week with transcatheter valve replacement, and we are treating low-risk patients, intermediate-risk patients, high and extreme surgical risk candidates. And in the future, we hope to be able to offer a full spectrum of valve replacements through a catheter-based approach. That's the goal, ultimately, is to see what other opportunities we can offer to patients down the road.
You're not just a mechanical device implanter. You're doing something that has extraordinary impact on a patient's life. We have to evaluate all of you, not just the heart, to make the most appropriate decision. And it really is essential that that be done by someone to whom it really matters, not just someone who wants to do a procedure. In this particular kind of technology, both the surgical side and the catheter-based side, it's just a delight to work with all of the folks involved, because there's not a weak link in this chain. They're really, really good.
Welcome back, everybody. Right now, before we go ahead and show you this next video, this is kind of going to be a behind-the-scenes tour of our new hybrid operating room and Cath lab, which just opened about 1.5 years ago, right, Mike? Yep. About 1.5 years ago. This room is going to look a little bit different than the room you initially saw in the beginning where we had the heart attack patient. This one's considered a hybrid lab because we could actually do Cath lab procedures and we could actually do open heart surgery if we needed to. And Dr. Adesanya is going to kind of give you a behind-the-scenes tour of the whole area. But in the meantime, we encourage you to ask us questions in the chat box, because after the end of this video, we're happy to answer any questions that you guys have about anything about anything about the procedures or anything about nursing or physician or anything at all, we're happy to address.
Hello everyone, my name is Cath. I'm an interventional cardiologist. I'm the director of the structural heart and valve team here at University Hospitals. Basically what I do, I replace and repair heart valves in a minimally invasive fashion with catheters. I'd like to welcome everyone to our facility, to our top-notch suite. Here we do a lot of different heart procedures, and I'm going to introduce you to this place that I almost call home because I'm here working every day. So come with me, I'm going to show our facility. Hi everyone, so welcome to the reading suite. So this is where physicians read results of MRIs and CTs. These tests are very important to help us understand some disease mechanisms. In addition to that, these tests help us plan the procedures we're going to do in the invasive suite that I'm about to show you. I would like to encourage everyone to participate in the chat. Please ask questions to us. It's going to be a very interactive chat, and we're going to be able to answer as many questions as you'd like to. Let's go to the invasive suite now. I'm going to show you where the action actually happens. Come with me. So here we are in the control room. So this is basically the cockpit, right? We're going to fly the airplane from here. As you can see here, we have the control room basically has two rooms that it takes care of. One of them is the CT room. The CT is basically that big donut. And what we do with that is we can see the patients from inside. It's a big X-ray machine that is able to perform several different cuts of the patient that we can have very detailed imaging. So it's very important for us to plan what's going to happen in here, which is the interventional suite. So come with me, and I'm going to show you details of the interventional suite. Very exciting. Welcome to the hybrid room. This is where I work every day. This room is interesting. We call it hybrid. I believe everybody's curious why we call it hybrid. The reason why is because this room enables us to do minimally invasive procedures, but we can also do open heart surgery here. And this equipment, this machine that you guys see here, is a machine that the patient goes on it, and what we do basically, that's a big X-ray machine that can spin around the patient, so we can get different angulations, and we can see our catheters, everything that is going on inside the patient, our catheters, our wires, and everything we can see on this machine. This is actually a robot that I can actually show you how this works basically. So look at the arm of the robot that comes here, and I can move this table. Imagine a patient on top of the table here. So the table goes, and this is going to spin around the patient. We can go right and left, and we can go cranial and caudal. So that's what it is. So this room enables us to do very complex procedures, and we do all of the minimally invasive procedures, the ones that I mentioned that we do. We repair valves, and we replace valves. That's where everything happens, and enables us to do open heart surgery as well. It's a very exciting place. It's a big room, and enables us to deliver the very best possible care to our patients. So don't forget to ask your questions on our live chat. We're very excited about it. And now I'm going to have Mike Morrison come in here, and he's going to dissect a heart. He's going to show you every detail of what a heart looks like. So let's go.
Hello and welcome to University Hospital's Cleveland Medical Center here in the Humphrey Hybrid Lab. My name is Michael Morrison, and I work here with the Division of Cardiac Surgery. So the size of the heart, everybody asks about how big is the size of your heart? Well, if you take your hand out and hold it flat, you're giving somebody a high five, and you make a fist, tuck your thumb out just a little bit and put it right here in the middle of your sternum. That's about how big your heart is. And how much blood does it actually pump to your body? Well, it actually pumps 1,000 beats a day. That's a lot of beats. So first off, we're going to take a look at some of the structures that we see on the outside of the heart. First off, we see the aorta, and that's where blood goes out of the heart into the rest of the body. As we can see here, this is the pathway that the blood takes. There's two different branches that come off of the aorta. Now in humans, there's normally 3 of these branches, but in pig hearts, there's only 2 branches. One is here, and this is the brachiocephalic, and the other is right here. That's the subclavian. On the outside of the heart, you have these two bat wing looking structures. These structures are called the atria. These are the receiving chambers. On the outside here, the wider part of the heart, this is called the apex or the point, and it's surrounded by two different areas. Both of these are the ventricles, the right ventricle and the left ventricle. So let's take a look at the aorta now, and let's see about the blood flow on the inside. And as you see, we are cutting into the aorta, and we're cutting just those two head vessels that we talked about a minute previous. We're going to cut through those so we can transect and look inside the aorta. Now, as you see inside of this aorta, we're going to see a valve-like structure. That is your aortic valve. We're going to cut into the heart, and let's see the four valves that we have. So we're going to make an elongated cut. This kind of cut is called a duckbill cut. And this should open up and let us see all of the valves of the heart. So now let's talk more about those valves. So there's four different valves in the heart. There's the aortic valve, which is a tri-leaflet valve, which means it has three leaflets. There's the pulmonic valve, which takes blood to the lungs. There's the tricuspid valve and the mitral valve. Let's take a look at them now. As mentioned before, the aortic valve sits here. The pulmonary valve sits way back in there. The mitral valve is here, which is a two-leaflet valve. And the tricuspid valve, which is here. So don't forget, if you have questions about what you're seeing, type it into the comment box and we'll respond back to you. So now let's talk about the coronary artery. So in order for the muscle to beat, it has to have blood flow. So in the heart itself, it has coronary arteries, both coming off the left and the right. So whenever we do bypass surgery, we have to wear these special kind of glasses that actually lets us see us very, very fine-tuned in the coronary arteries. As we see here, this is one of the coronary arteries called the LAD. This actually takes blood all the way down to the apex of the heart. When we actually sew sutures onto the heart and vein grafts, we use very, very tiny suture. This suture here that you see is actually smaller and thinner than an eyelash. All right, so let's talk about the blood flow in the heart. So blood comes into the vena cava through the SVC, the superior vena cava, and the inferior vena cava, from above and below, and it comes into the right atrium. It goes into this right atrium, into the right ventricle over here. From the right ventricle, it contracts and sends blood to the lungs through the pulmonary artery. From the lungs, it comes back to the pulmonary vein into the left atrium, as we see here. From the left atrium, it goes into the left ventricle. Blood flow then comes in through the aortic, or goes out through the aortic valve and out to the rest of the body. So blood comes in from the lungs, in through here. This muscle contracts and blood shoots through the aortic valve, which we had saw here, and goes out to the rest of the body. So this is the actual pathway of blood going to the rest of the body. So that sums up the quick overview anatomy of the heart. There are a couple differences between the human heart and the pig heart. If we look at the shape, so you see here, it's more of a traditional heart shape like you would see as you would write a Valentine, whereas the human heart is a little bit more of a trapezoidal shape. Also, another distinct feature and difference between the human heart and a pig heart is the coronaries. In a human coronary, the left coronary is short, whereas in a pig it's very long. In a pig, the right and the left coronaries are about the same length. In a human, the left coronary is a lot smaller than the right. The right coronary wraps all the way around the heart. But in a pig heart here, the right coronary wraps all the way around to the apex, as well as the left. In the human, the coronaries stop right above or right after the aorta. So that concludes our dissection here at University Hospitals, and the Cleveland goes red for STEM. We thank you, and if you have any questions, don't forget to write us in that chat box. Have a good afternoon.
really cool.
Thanks.
Dr. Adesani was able to join us, so he could answer any questions that you guys have. Dr. Adesani is our director for our Structural Heart and Valve Center, and you saw him in a couple of our videos. So we're going to actually go to answer a couple of questions. So I know a couple of people asked, but it was a pig's heart that Mike was dissecting. The first question that we have actually was from Isabella. She asked, and I'll direct this to Dr. Adesani, what was the actual valve made of that you used in the structural heart video?
Yeah, so the valves are made of either pig or cow tissue. So they're actually handmade, those valves. They're not the actual valve of the pig or the actual valve of the cow, but rather it's made with their tissue. So it's a handmade valve made with either cow or pig tissue.
Thank you.
Mm-hmm.
Mike, I'm going to give you the next question. Natalie wanted to know, she wants to work in a NICU. What classes should she be taking?
Oh, good question, Natalie. So you want to take a lot of science-based classes, a lot of biologies, a lot of chemistries. If your school offers any kind of health classes, that would be a good start. Also, get into shadowing. See if you can shadow at your local hospitals. Talk to nursing or a lot of your nurse friends. Get their opinion on it. That's a very good start and a very good question.
Okay, next question. How many different types of heart surgeries are there, and do you ever use any other scans besides the CT scan?
Yeah, there are many different types. I don't know precisely how many. There are heart surgeries that can accomplish different or can tackle different diseases that we have in our heart, either heart valves, coronary artery obstructions, or defects that have sometimes people have holes in their hearts where they shouldn't have. So there are many different types of heart surgery. For most of these surgeries, we do have to do a comprehensive planning prior to the actual procedural date. And the CT scan plays a very important role. Of course, you use other imaging modalities such as echo and MRI, but yes, and heart catheterization as well. But yes, the CT scan plays a major role in most of the heart surgeries planning.
Okay, next question comes from Isabel Tapuccio. She wants to know, how long can an open heart surgery last? And Mike, we're going to actually do this twofold because I think someone earlier had asked, how long does heart transplant surgery last?
Okay, so regular heart surgery normally takes about 4 to 6 hours, depending on what we're doing, whether we're revascularizing the coronaries or we're replacing a valve. A heart transplant takes a lot longer than that. There's a lot of coordinating between having to go out and get the heart and come back. Normally, a heart transplant normally takes about 8 to 10 hours.
Okay. So Amy had commented in here, and I just want to reinforce what you said. It's important to talk to your school counselors, and they could connect you with people that you could shadow or talk to about opportunities to go into the STEM field. Next question.
So one right below it.
That's actually open heart as well.
No, the biomedical plastics. Elizabeth, can you scroll back up?
Yep.
So Elizabeth asked, if you wanted to go into biomedical plastics, what major would you take? So in some colleges, they offer a biomedical degree in colleges. So in order to set that up, you would want to take a lot of your biologies and chemistries and a lot of mathematics. There's a lot of mathematics and engineering that go into biomedical plastics as far as like amputations for limbs. So that's a good question. So take a lot of science and math-based classes.
Okay, well, this question actually I'm going to answer, and I'm going to have Dr. Adesani and Mike answer as well. It says, what is your work-life balance? Do surgeons have free time? So I'm going to answer it first from a nursing perspective, because I'm, of course, for nurses, and Dr. Adesani and Mike can answer. So I will tell you, work-life balance is tough, but at the same time, it's actually gotten better. I've been a nurse at UH for 34 years, and it actually has changed a lot. I think work-life balance is definitely a little bit challenging, but I do think it's changed a lot as far as there are positions available in nursing that you can do just day shifts. So I do encourage you to explore nursing opportunities.
Yeah, I think it's challenging, as Stacy mentioned. obviously, this procedures that we do, not only the procedures, but everything, all patient care requires a lot of time. We do, not only we perform procedures and we do patient care, but also we do a lot of research, and all of this demands a lot of dedication and time, right? But yes, you have to try to, despite your dedication to what you do and your passion to what you do, you have to always find time to dedicate to your family, and the ability to manage time is very important to be able to, be successful in your career while still, provide good, be with your family and enjoy time together. So I think you have to find a good work balance. It's always possible to do that.
From a surgery standpoint, the work-life balance is rough. We sometimes we do 10, 12, 14-hour surgeries, and that does take a toll on you, and all you want to do is sleep the next day. But it's very important to find something outside of here that you love to do, that you can dedicate yourself to. But yes, work-life balance is tough, but it is achievable.
Next question for Dr. Adesany. Are surgeries stressful for surgeons?
Well, we have a lot of experience with what we do. So surgery for me is the same thing that I'm going to just make a comparison that if you go to Starbucks, whoever works at Starbucks is gonna pour a coffee for you. It's basically the same thing. That's what I do for a living. So it's not stressful. I'm always, when I'm doing the procedure, I'm always focused. I'm always very concentrated on what I'm doing, and I'm very confident on what I'm doing. So it's not stressful. It's a moment of concentration, a moment that that have somebody's life in your hands. But I don't think it's stressful. It's not stressful to me. I think it's can you imagine? I do this every day, right? That's what I do for a living. So I'm very confident that I'm not stressed when I'm doing it. I'm just very concentrated.
Some great questions. So Avery is asking, how did you find cardiac areas in the medical field? How did you get into it instead of other specialties or the general medical field? So what made you go into cardiology?
Oh, that's a long answer. But basically, I've always liked cardiology. To be honest, I wanted to be a surgeon when I started med school, and but then progressively I fell in love with cardiology, and I found something in between. I'm an interventional cardiologist, so I am a cardiologist, but I perform minimally invasive procedures. So I kind of I was able to basically have both of the things that I like at the same time, being an interventional cardiologist. So yeah, that's how it happened.
So for me, in high school, actually, believe it or not, I was a firefighter, and I just loved helping people. So right out of high school, I went to a technology program. It's a surgical technology program where you kind of scrub into the OR and you kind of get to hand them the instruments. And from there, it was kind of just, I fell in love with cardiac surgery. That was the most complex, the most, in my mind, the best kind of surgeries to do. So that's kind of how I got into the medical field.
Thank you, Mike. So next question is for Dr. Adesany. How do you know which method you use to put the patient to sleep? How do you choose?
Yeah, so normally for my procedure, a lot of my procedures, I don't put the patient to sleep. That's actually the beauty of these minimally invasive therapies, that we can actually do only with local anesthesia, so patients can be awake while I'm replacing their valves, right? Whenever there is a procedure that requires anesthesia, then yes, then who decides the method to do that is actually the anesthesiologist. It's not going to be myself, but rather it's another specialty, anesthesia, who decide how the process of anesthesia is going to happen.
Thank you. So Lauren, great question here. So Dr. Adesany, in the beginning of the video, Dr. Simon was talking us through a STEMI, and he was referring to, and Lauren wants to know, what was he saying when he was saying balloon up? What does that mean?
A balloon up?
Yes.
When you're ballooning something, probably. I didn't.
It was a STEMI video.
Yeah, so that there was ballooning. There was an obstructed artery. They were inflating a balloon to basically remove the clot from it.
Okay. Next question, we have time for a couple more questions. We answered that one. Do you ever get days off? Yes, we do get days off. Our doctor shows exaggerated. So when you watch Grey's Anatomy and Transplant and all those shows, what would you guys say? Are they exaggerated?
To be honest, I don't watch them. So I think many years ago I used to watch the ER. I think they were actually quite good. I mean, they would reflect a lot of real world challenges and that we have. But I don't really watch those shows, very frequently. So I don't know. Do you watch them, Mike? I don't.
Well, I mean, I'm guilty of it. I'm not gonna lie. So most shows are fairly accurate. It is painful to watch some of those because they're like, that's not what we do. That's wrong. And you point it out. But I would say the most accurate. I know everybody's typing Grey's Anatomy. I see Grey's Anatomy. But The Good Doctor is probably the most accurate show that I don't scream or throw something at the TV because it's wrong about.
Okay, last question that we're going to answer because I feel it's an important one. And actually it's twofold. How many surgeons are in a room at the same time? And also, do you get breaks in the middle of surgeries?
I don't get breaks, and depends on which procedure you're doing. That depends. Maybe only one, maybe more than one. Depends on what procedure it is.
Yeah, for open heart surgeries, normally there's one surgeon in the room and myself. Sometimes I'll have a colleague, another surgical assistant with me. If we're doing bypass surgery, we take the vein from the leg endoscopically. So we'll have one extra person in the room there. Occasionally we'll have another surgeon join us if it's a very, very complex surgery. Do we take breaks? Rarely do we take breaks in open heart surgery.
Very great questions, you guys. Thank you so much. So now I'm excited to share with you some information that is very near and dear to University Hospital, Harrington Heart and Vascular Institute's Heart, and American Heart Association. You will learn about some hands-only CPR training, followed by a very special survivor story. Please pay very close attention because someday you may need to do CPR on someone. Let's take a look.
The American Heart Association's mission is to be a relentless force for a world of longer, healthier lives. You too can be a relentless force by learning hands-only CPR. We've got a question for you, and we want you to put your answer in the chat box. Do you know how many people each year in the United States have a cardiac arrest outside of a hospital? Is it 100, 5,000, 100,000, or 350,000? If you answered 350,000, you're correct. Each year in the United States, more than 350,000 people have a cardiac arrest outside of the hospital. This is why it's so critical that you learn to perform CPR, and this short video is going to show you how.
So, tell me, young man, do you remember what your dad and I taught you about hands-only CPR?
Yes. Kind of.
If you see a teen or adult suddenly collapse, the first thing you do is...
Call 911.
And the second thing you do is...
Push hard and fast in the center of the chest at a rate of at least 100 beats per minute.
Who even knows what 100 beats per minute sounds like?
Well, you can tell by the way I use my vocal performance. No time to talk. Music's not women falling, kick crowds inside the ball. It's alright, it's okay. You may love the other way. We can try, understand, do yourself straight up.
Remember, it's only 2 steps. Call 911.
And push hard and fast in the center of the chest to the beat of Staying Alive until help arrives.
Staying alive. Staying alive. stay alive. Stay alive. Stay alive. Stay alive.
Wow, that video really inspired me to learn CPR. It's so easy, right? Now here's a question to test what you just learned. Put your answers in the chat box again. True or false? Hands-only CPR requires 2 steps. If you answered true, that's correct. Hands-only CPR has just 2 easy steps, performed in this order. Call 911 if you see a teen or adult suddenly collapse. Push hard and fast in the center of the chest to the beat of a familiar song that has 100 to 120 beats per minute, like Staying Alive or Beyonce's Crazy in Love. Now we want to introduce you to a special girl named Alexa. She was born with a congenital heart defect, also known as CHD. Do you know what that is? A congenital heart defect results when the heart, or blood vessels near the heart, don't develop normally before birth. Let's watch her story now.
Alexa was born in 2011. She came a little bit early, quite a surprise baby. She came at 33 weeks. She was born with a congenital heart defect. She had a hole in her heart, and she had a missing pulmonary valve. That was a little scary at first, but we had excellent doctors that educated us on the condition. Before she turned 1, she had her first surgery to close the hole in her heart. Then before she turned 2, almost exactly a year to the date of the first surgery, she had her first open heart surgery where they went in and put in that missing pulmonary valve. And then last year in October, she had her second open heart surgery where they replaced that pulmonary valve with a new valve. There are so many children with heart conditions. I wasn't aware at all how many children there are that are affected by this. We've been in the hospital for several different occasions for different issues that she's had. She has just been full of energy the entire time. Her heart condition has never slowed her down.
I tell people drink lots of water and fluids and exercise every day. Because if you don't have a healthy heart, that's really bad.
That's the message she really wants to get across to other kids.
Wow. Alexa is an inspiration to all of us. Did you know that out of 1,000 births, at least 8 babies will have some form of congenital heart disorder? Hopefully, these videos have given you a greater appreciation for the life-saving work of the American Heart Association and inspired you to want to help solve some of these problems by becoming a physician, researcher, scientist, or specialist in a STEM field. Now we want you to head back to the main agenda and click into Session 4, Meet the Experts.